So thank you all so much for having me today. Like was said, my study was called Pulmonary Function Tests as an indicator of postoperative pulmonary complications in patients that are undergoing abdominal wall reconstructions. And I worked on this at UAB under the direction of Dr. De La Torre. So abdominal wall reconstruction is a technique that's used for repair in large and complex recurrent hernia repair. And as any surgical procedure, it comes with its risk of postoperative complications, with respiratory complications no different. However, there isn't a current consensus on how to predict what patients might be at a higher risk of developing postoperative pulmonary complications. Some studies have looked at different aspects of respiratory function following abdominal wall reconstruction, or AWR, and they've identified risk factors such as age, male sex, congestive heart failure, lung disease, obesity, and then obstructive sleep apnea. However, those are just associated with the development of respiratory failure, not all respiratory complications that can happen after a surgery. And then in addition, some studies have looked at the impact of AWR on pulmonary function tests, but not the impact of pulmonary function tests on predicting AWR complications. So there hasn't been a correlation between what we specifically looked at, which is peak inspiratory pressure and an increased rate of postoperative pulmonary complications. So our goal with this study was to see if there's a link between those two. So we did an IRB-approved retrospective review on all patients that underwent abdominal wall reconstructions due to ventral hernia development at our tertiary care center from January of 2017 to September of 2022. We looked at patient demographics, procedure information, and then intraoperative PFTs that were included on the anesthesia record. And then we saw if there were any postoperative respiratory complications. And for that, we divided it into major complications in which the patient required a BiPAP machine or ventilator, and then minor complications, which could resolve with antitussives, antibiotics, additional oxygen, nebulizers, or occasionally resolved with no treatment. And different complications that were recorded were acute respiratory distress syndrome, atelectasis, pneumonia, dyspnea, increased oxygen requirement, and atelectasis. So for our results, we had an average age of 55. We had an average BMI of 33.67. We did not find any difference in data between the groups of the group of people that developed a complication and the group of people that did not. In total, we had 30.5 people develop any respiratory complication, but again, that seems very high. It could be a complication that resolved with no treatment. We just wanted to make sure we tried to catch everything that we possibly could. And only 5.95 developed a major complication, which again would have required the BiPAP and the ventilator. And this is pretty consistent with what some of the other studies have shown in terms of rates of major complications. So in terms of our two groups, our group that had a respiratory complication had a mean PIP of 21.65 centimeters of H2O, whereas our group that did not have a complication had a mean PIP of 18.55, which we did find to be significant. And it was significant after accounting for different demographic data like COPD, emphysema, smoking history, age, gender. It was independent of risk factors. It was still significant. And you can see in our figures below, as average PIP increases, you do see an increased rate of both the major and the minor complications. So in conclusion, we found that postoperative or intraoperative elevations in PIP are associated with an increased susceptibility to major and minor pulmonary complications following an AWR reconstruction. And we believe this is significant because it could help guide postoperative care strategies in patients that are undergoing abdominal wall reconstruction. If someone's noted to have a significantly increased PIP while they're in the operating room, it could be worth it to kind of look into how to potentially prevent the development of a complication. However, we do know that we need a larger and more extensive retrospective review in order to fully analyze these results. And it would be as well worthwhile to look into a prospective review to see if there's any way that we could prevent some of these from developing.